Hello again. This is Professor Triple N or Nick PA from Brooklyn, New York. And today is March 22, 11 p.m. Let's go over some slides. Gynecology on my Gynecology PANP board review notes. And once again, if you have any suggestions or advice, please feel free to email me at my email, nickmd1@gmail.com. Let's start with the breast, and the first is clinical scenario, which discuss a 52 years old woman with past medical history, high blood pressure, comes to your office for a physical exam. She feels well, although she's tired all the time. Her colonoscopy, mammogram, and pap smear are done at age 50, are normal. Her vital signs are stable. BMI is 29. Physical exam is normal. Which of the following the question is, which of the following screening test is indicated at that time? A. Colonoscopy. B. DEXA scan. C. Mammogram. D. pap smear. And E. Hepatitis B. The right answer here is C. Screening mammograms are recommended every other year in women between the age of 50 and 75. Colonoscopy every 10 years. In the general population, a repeat colonoscopy every 3 to 5 years if there is a polyp. Osteoporosis screening with DEXA scans starts at the age of 65. Pap smear is done every 3 years if cytology alone is done, or every 5 years if done in conjunction with HPV testing. So let's go to the next slide, slide number 2. Slide number 2 discusses breast cancer screening. Breast cancer screening for the general population, as we said, is age of 50 and ends at age of 74. Mammogram is the best screening test for breast cancer and has proven effective to decrease mortality. If the patient has a family history of breast cancer, the screening starts at the age of 40. There is something which is called BRSA screening, and this is genetic screening and genetic counseling for patients which have one family member with any ovarian, fallopian tube, or primary peritoneal cancer. Number 2, 2 family members with breast cancer under the age of 50. Number 3, 2 or more primary breast cancers. Number 4, personal history of triple-negative breast cancer diagnosed under the age of 60. Number 5, a male family member with breast cancer. Number 6, breast, prostatic, or pancreatic cancer diagnosed at any age with 2 relatives. And then the last one, number 7, is personal history of breast cancer under the age of 50. And we have here a clinical scenario which discuss a 55 years old woman comes to the office with because she felt a breast mass. The mass is painless and mobile and presented at the last 1 week. Her mammogram done last year was negative. Vitals are stable. Physical exam is significant for 3 by 3 centimeter round, firm mass, mobile, non-tender, located in the right breast at 4 o'clock position. No discharge or skin changes. No axillary lymph nodes enlarged noted. What is the next step of management of this patient? A. Biopsy. B. Mammogram. C. Breast ultrasound. D. Breast MRI. And C. No further treatment. The right answer here is B. Diagnostic mammogram is done when the first line test in women with palpable breast mass, regardless when the last mammogram was done. Even if the woman is under age of 30, a mammogram should be performed first. Breast ultrasound is done if the woman is breastfeeding or pregnant. Breast MRI is not a screening test. Biopsy is never the first step of workup. The mammogram results are given via breast imaging reporting and data system BIRADS categories. And this is on slide 3. We see category 0, incomplete, when you need additional imaging. Category 1, negative. We have a negative screening. Category 2, benign. We have a routine screening. Number 3, probably benign. Short-term follow-up, 6 months. Number 4, suspicious. Needs a tissue diagnostic. Number 5, highly suggestive of malignancy. Need tissue diagnosis. And number 6, non-biopsy with proven malignancy. Surgical excision is clinically appropriate. On this slide, let's discuss some breast cysts, breast lesions, but first let's start with the breast cyst. The breast cyst is presented as a painful or painless mass in the breast. Cysts may be related to the menstrual cycle and can arise suddenly and enlarge acutely. Physical exam findings are smooth, firm, discrete, and texture feels like grape or hard mass. Diagnosis or treatment is cysts are diagnosed as simple, complicated, or complex. And they're diagnosed via breast imaging. Let's go to the next slide, number. So let's talk about amenorrhea. Amenorrhea is when the absence of menstruation can be either primary or secondary. Start from slide number 6. Slide number 6, we discuss the difference between primary and secondary amenorrhea. Primary amenorrhea is defined as absence of menstruation by age of 15 in a female who has normal secondary sex characteristic. If a girl has not developed secondary sex characteristics such as breast by age of 13, begin workup for primary amenorrhea. The causes for primary amenorrhea includes gonadal dysgenesis or Turner syndrome, Mullerian agenesis, delay in puberty, PCOS, hypopituitarism, and we have to know that we always need to rule out pregnancy. The diagnostic tests. Initial testing for primary amenorrhea includes beta-ECG, TSH, prolactin, FSH, pelvic ultrasound. And the treatment depends on the cause of amenorrhea. Secondary amenorrhea is when absent of menses for more than 3 months in female who menstruate regularly, or absence of menses for 6 months in female who menstruate irregularly. The causes of secondary amenorrhea includes pregnancy. This is the most common cause of secondary amenorrhea. Hypothalamic amenorrhea. Let's go to next slide. This slide discusses so-called premenstrual syndrome and premenstrual dysphoric disease, or PMS and PMDD. This occurs when the women are 20 or 30 years old. PMDD is just a severe version of PMS and usually disrupt the patient's daily activity. Symptoms include headaches, breast tenderness, pelvic pain and bloating, irritability, and lack of energy. Diagnostic tests. There is no test for PMS and PMDD, but we have to remember that PMDD has a DMS-5 diagnostic criteria. And we'll talk about the chart syndromes. The following must be presented to meet the diagnostic criteria. Symptoms need to present in 2 consecutive cycles. Symptoms repeated of 1 week in the first part of the cycle, which is follicular phase. Symptoms must be presented in the second half of the cycle, which is luteal phase, and needs to have dysfunction of the life. The treatment for this clinical scenario, clinical problem is patients need to decrease consumption of coffee, alcohol, cigarettes, chocolate, and start exercising. If symptoms are severe, we need to give a SSRI. Let's talk about menopause. We're on slide 8. Menopause is a result of permanent loss of estrogen. Usually occur age of 48 to 52. It starts as irregular menstrual bleed. The oocytes produce estrogen and progesterone. So the both LH and FSH start to rise. Women are symptomatic for average of 12 months. But some women can experience symptoms for years. So the symptoms include menstrual irregularity, sweats and hot flashes, mood changes, pain during sexual intercourse, or dyspareunia. Physical exam, we need to remember that decreased estrogen causes osteoporosis. Physical exam finding includes atrophic vaginitis, decrease in breast size, and vaginal and cervical atrophy. Let's go to the next slide. This slide discusses the diagnostic and treatment of menopause. If the diagnosis is unclear, so we need to increase the FSH level to see that there is an increased FSH level. HRT or hormone replacement therapy is indicated for short-term symptomatic relief or prevention of osteoporosis. Contraindication for HRT includes estrogen-dependent carcinomas such as breast and endometrial cancer, and history of PE or DVT. And we need to remember a clinical fact that HRT is associated with endometrial hyperplasia and can lead to endometrial cancer. Let's talk about some abnormal uterine bleedings. Start with menorrhagia. This is when we have heavy and prolonged menstrual bleed, gushing of blood, and clots. Etiology is usually endometrial hyperplasia, uterine fibroids, dysfunctional uterine bleed, and uterine device. Next is so-called hypermenorrhagia. We have light menstrual flow, may only have spotting, and the etiology is usually obstruction, such as hymen or cervical stenosis, and also oral contraceptive pills. Number 3, so-called metrorrhagia. Usually we see intermenstrual bleeding, which is caused by endometrial polyps, endometrial or cervical cancer. Let's go to the next slide, number 10. Or exogenous estrogen administration. Other bleeding is so-called menometrorrhagia, which is irregular bleeding. We need to look at the time intervals, duration, and amount of bleeding. Also, we need to look at endometrial polyps. It's due to endometrial polyps, endometrial cervical cancer, exogenous estrogen administration, and malignant tumors. Another type of bleeding is oligomenorrhagia, when you have menstrual cycles over 35 days long. It's due to pregnancy, menopause, significant weight loss, anorexia, and tumor secreting estrogen. The last one is postcoital bleeding. This is bleeding after intercoitus. It's caused by cervical cancer, cervical polyps, and atrophic vaginitis. The clinical tip is that postcoital bleeding is cervical cancer until proven otherwise. The diagnostic tests are CBC to see the hemoglobin and hematocrit levels, PT-PTT to evaluate for coagulation disorder, pelvic ultrasound to visualize for any anatomical abnormality. Then we have on the bottom of this slide so-called DUB or dysfunctional uterine bleeding, which is unexplained abnormal bleeding. Usually occurs in patients which are anovulatory. Usually the ovary produce estrogen. Let's go to the next slide. But the corpus luteum is formed. Without corpus luteum, progesterone is not produced. This prevents unusual withdrawal bleeding. The continuous high estrogen continues to stimulate growth of endometrium. Bleeding occurs only once the endometrium outgrows the blood supply. Diagnostic test: we need to rule out systemic reasons for anovulation such as hyperthyroidism and hyperprolactinemia. Endometrial biopsy for women over 35 to exclude carcinoma. The clinical tip is that there is no specific test for DUB, only it confirms by excluding other causes. And another thing is every patient older than 35 with abnormal bleeding should undergo endometrial biopsy to rule out endometrial carcinoma. The treatment is OCP or oral contraceptive pills. Usually this is adolescent or young women which are anovulatory and women over 35 which have a normal endometrial biopsy. If there is acute hemorrhage, you do a DNC to stop the bleeding. DUB is severe if the patients are anemic and they are not controlled by OCP or report that their lifestyle is compromised. Treatment with endometrial ablation or hysterectomy. Dysmenorrhea. This is a painful period. It's common complaint during menstruation and present as a crampy lower abdominal pain. Dysmenorrhea. Let's go to the next slide. Openly treated with at home, non-pharmacological. This motherfucker, why calling me? Vadim. He's crazy. I'm gonna talk to him about 2 years, 3 years. So usually when you you apply heat to the abdomen. Exercises or sexual activity can also decrease the symptoms. The best initial treatment is NSAIDs, and hormonal contraception also can reduce the symptoms. Clinical tip is that postmenstrual bleeding means that the patient needs endometrial biopsy. Okay, so let's here discuss postmenstrual bleeding. Postmenstrual bleedings are usually vaginal bleeding in women which has already gone through menopause. It is considered endometrial cancer until proven otherwise with endometrial biopsy. Other etiologies of postmenstrual bleeding includes atrophy, polyp, endometrial hyperplasia, leiomyoma, endometriosis, anticoagulation, and infection. Postmenstrual bleed itself is self-limited and management is limited also as well. the main objective is to rule out cancer. This slide also discusses contraception. Let's talk about the first one, female condoms. Female condoms has 2 rings and thin material between. One ring is placed deep into vagina, another is left at the outside. Female condoms openly protect from HIV or STD. And there, let's go to the next slide. They're under female control. They are larger and bulkier than the male condoms. Another one is number 2, vaginal diaphragm. The vaginal diaphragm is circular ring with contraceptive jelly and covers the cervical canal. The diaphragm without contraceptive jelly is ineffective. The contraceptive jelly is used as a lubricant while placing the diaphragm. The diaphragm should be placed before intercoitus and left for at least 6 hours after that. The disadvantages of this diaphragm are, number 1, needs to be fit properly. Proper use requires advanced preparation, and inappropriate placement or dislodging reduce the efficacy. Next one is number 3, oral contraceptive pills or OCP. They are mostly combination of pills with both estrogen and progesterone. The pill is taken 21 days and the placebo is taken for 7 days. During the 7 days placebo pills, the patient will experience menstruation. Women should start usually the oral contraceptive pills on Sunday after menstruation. OCP reduces the risk of ovarian cancer, endometrial cancer, and ectopic pregnancy. But they also increase the risk of thromboembolism. Next one is vaginal ring. Vaginal rings are flexible vaginal rings that release both estrogen and progesterone, and they insert it in the vagina for 3 weeks. Hormones are released on constant basis. When the ring is removed, withdrawal bleeding will occur. Vaginal ring has similar effects and efficacy of OCP. Next one is transdermal patch. The transdermal patch is a combination of estrogen and progesterone which is placed on the skin every 7 days. Each week the previous patch is removed, a new patch is placed. 3 weeks of patches are followed by patch-free week, during which the patient will experience withdrawal bleeding. Let's go to the next slide, number 14. The patches should not be placed on the breast. The side effect and efficacy is the same as OCP. Intramuscular injection. This is slide 14. Depot medroxyprogesterone acetate is an intramuscular injection that is effective for 3 months. Next one is intrauterine device or IUD, which is placed in the uterus and provides contraception for 10 years. There is 2 types, Cooper device and levonorgestrel device. These devices are associated with pelvic inflammation disease when they're placed. Genital culture usually done before placement of these devices. Another form is sterilization, which is surgical sterilization, can be done both on men and women. This could be done via tubal ligation or vasectomy. Both are permanent and reversed only by surgery, which usually is not successful. Tubal ligation is a surgical procedure when women may choose to undergo for permanent contraception. The risk of pregnancy is very low, but it may occur, and this increases the incidence of ectopic pregnancy. Wow. Vasectomy is a surgical procedure in which ligation of the vas deferens is performed. Let's go to the next slide, which is slide number 15, and we'll talk about vulva and vagina. Let's start with labial fusion. Labial fusion occurs when we have excess androgens. This can be occur with external androgen administration or by increased androgen production. The most common of labial fusion is 21B hydroxylase deficiency. The treatment is reconstructive surgery. And here let's talk about epithelial abnormality. On this table, we have three of them: lichen sclerosus, squamous cell hyperplasia, and lichen planus. Lichen sclerosus usually occur in any age. However, if postmenstrual, there is increased risk of cancer. Description is white thin skin extending from labia to perianal area. Treatment is usually with topical steroids. Next one is squamous cell hyperplasia. Occur in any age. Patients who have had chronic vulvar pruritus, they are complaining of that. Description is patients with chronic irritation develop hyperkeratosis, which is raised white lesion. The treatment with sitz baths or lubricant, which help to relieve the pruritus. And the last one is lichen planus, between the age of 30 to 60. These are usually violet or flat papules, and the treatment with topical steroids. Next, we need to talk is about Bartholin gland cyst. Usually is located in the lateral side of the vulva. It secretes mucus and when become obstructed, become cyst or abscess, which cause pain, tenderness, and dyspareunia. Physical exam shows edema, inflammation at the area of deep fluctuating mass. Let's go to the next slide. Here we see on figure 17.1 Bartholin gland cyst. We have the clitoris, labia minora, urethra, the skin gland, vagina, and the Bartholin gland. The treatment of is similar as other cysts or abscesses. It needs to be drained. simply needs to be is IND. If continue recurring, marsupialization should be done. During IND, the fluid release should be culture for STD, such as Neisseria gonorrhea or Chlamydia trachomatis. So this is slide 16. Marsupialization is a form of IND which the open space is kept open with sutures. This allows the space to remain open and decrease the risk of recurrency. Let's talk about vaginitis. We have a clinical vignette here. 19-year-old woman presents with vaginal pruritus and discharge for 1 week. She complains that discharge is green and profuse. She has multiple sexual partners for the last 2 months. The last menstrual period is 2 weeks ago. On a wet mouth, vaginal discharge shows motile flagellate organisms. The question here is, let's go to the next slide, 17. The question here is, which is the most likely diagnosis? Number A, chlamydia. Number B, bacterial vaginosis. C, Neisseria gonorrhea. D, Candida. E, Trichomatis vaginalis. Answer is E, Trichomatis vaginalis presents with profuse green frothy discharge. Neisseria is bacterial infection which is identified by culture. Chlamydia is diagnosed by serological DNA probe. Candida is associated with white, cheesy vaginal discharge. And bacterial vaginosis is associated with vaginal discharge which is with fishy odor without pruritus. We have risk factors for that. Any factor which increases the pH of the vagina can help to form vaginitis, which is antibiotic use. Bacillus usually normally keep the vaginal pH below 4.5. Also in diabetes, in case of diabetes, also when you have overgrowth of normal flora. On this table, we can see the types of vaginitis. Also, we need to mention that the patients are complaining of itching, pain, abnormal odor, and discharge. If you have a bacterial vaginosis, you have Gardnerella. If you have Candida, you have Candida albicans. The discharge is usually in Gardnerella or bacterial vaginosis. Fishy odor, gray to white discharge. Saline wet mouth shows clue cells. In Candida, you have white cheesy vaginal discharge, and KOH shows pseudohyphae. Let's go to the next slide. Slide number 18. On figure 9.2, we'll see clue cells, and figure 9.3, we'll see how the pseudohyphae look like. The treatment is for let's go to so we're on slide number 18. The treatment for the first one, which is bacterial vaginosis, is with metronidazole or clindamycin. And the second one, which is Candida, We treat with miconazole, cotrimazole, econazole, or nystatin. There is a clinical tip is that here if trichomonas is diagnosed, both partners needs to be treated. We're still on slide 18. Let's talk about malignant disorders. We'll start with so-called Paget disease. Paget disease, this is intraepithelial neoplasia, which occur in postmenstrual Caucasian women. Paget usually presents with vaginal soreness and pruritus, appears as a red lesion with a superficial white coating. The biopsy is needed for defined diagnosis. Treatment for bilateral lesion is usually radical vulvectomy. And if there is no if there is unilateral lesion, usually modified vulvectomy is done. Let's go to the next slide, slide number 19. Slide number 19 discuss so-called squamous cell carcinoma. Squamous cell carcinoma is the most common type of valvular cancer. Presents with pruritus, bloody vaginal discharge, and postmenstrual bleed. Physical exam can range from small ulceration to a large cauliflower-like lesion. Biopsy is essential for diagnosis, and staging needs to be done while the patient is in surgery and determine the following. Let's look at this next table. This is table for staging of squamous cell carcinoma. Stage 0, this is carcinoma in situ. Stage 1, limited to vaginal wall less than 2 cm. Stage 2, limited to vulva or perineum more than 2 cm. Stage 3, tumor spreading to lower urethra and anus, and unilateral lymph nodes presented. Stage 4, tumor invasion of the bladder, rectum, and bilateral lymph nodes. And stage 4A, distant metastasis. Treatment for unilateral lesions without lymph node involvement is usually modifying radical vulvectomy. Treatment for bilateral vulvectomy is usually radical vulvectomy, and lymph node they must undergo lymphadenectomy. I mean surgical removal. That's what is the meaning of that. Let's talk about cervical abnormality. We're still on slide 19. We need to discuss here cervical cancer screening. Usually in asymptomatic immunocompetent women, cervical cancer screen starts with pap smear at the age of 21, regardless of sexual activity. In women younger, let's go to slide 20. Younger than 20 years old, screening with pap smear alone is done every 3 years. After age of 30, either pap smear alone every 3 years or pap smear with HPV co-testing every 5 years, as long as both tests are negative. What about if we have abnormal cervical cancer screening? Uh, wow, this is very hard. So let's talk about that. Patients with abnormal screening test should have a prompt follow-up with the following recommendations. One unsatisfactory PAP test is not a reliable indicator of disease. Repeat the test every 2 to 4 months. There is two options for management of abnormal HPV. With negative PAP in patients older than 30 years old, you do HPV DNA typing or repeat the co-test in 1 year. If you have management of normal PAP results, different based on the results, you do a typical glandular cell presentation, colposcopy with endometrial sampling. You do a typical endometrial cancer, which includes endometrial or endocervical sampling. You do a typical cell of determined significance or ASCOS. There is two options. HPV testing now is preferred, is when you have positive or colposcopy and negative, you repeat the co-testing in 3 years. If you have repeat PAP test in 1 year, you have positive colposcopy and negative, resume routine screening. If you have so-called low-grade squamous intraepithelial lesion or LSIL, HPV testing is negative. Repeat co-testing for 1 year, within 1 year. 1 year test negative for ASC or HPV, repeat in 3 years. 1 year test positive for ASC or HPV, do a colposcopy. HPV testing is positive to colposcopy. No HPV testing, do again colposcopy. Wow. If you have a high-grade squamous intraepithelial lesions, you do either colposcopy, let's go to the next slide, or lip procedure. In this slide, we need to talk about so-called HPV prevention. HPV vaccinations are strongly recommended in women and permissible in men. It is administered in both male and female patients starting at the age of 11 with goal eradication of HPV and prevention of cervical cancer before it starts. Males can get vaccine at the age of 21 and females at the age of 26. In addition, men who have sex with men and men with weakened immune system can be vaccinated at the age of 26. Let's discuss here uterine abnormality. Let's start with adenomyosis. Adenomyosis is invasion of endometrial glands into the myometrium. This usually occurs in women of age of 35 to 50. Risk factors include endometriosis and uterine fibrosis. Usually presents with dysmenorrhea and menorrhagia. Adenomyosis is a clinical diagnosis and physical exam. Uterus is large, globular and bulgy. MRI is the most accurate test, and hysterectomy is only definitive treatment. The only way to diagnose adenomyosis definitively, this is by hysterectomy with biopsy. Let's go to the next slide, slide 22. Here we have on figure 9.5, microscopic sample for adenomyosis. And on slide 9.6, we have histopathology of image of the uterine adenomyosis. Okay, let's go to the next slide. This was easy. Slide number 23. Endometriosis. On this slide, we will discuss the endometriosis. This is implantation of endometrial tissue outside of the endometrial cavity. The endometrial tissue can be implanted everywhere. The most common sites are ovary and pelvic peritoneum. Usually occur in women with reproductive age and most common in first-degree relatives, mothers and sisters. Endometriosis presents with cyclic pelvic pain, which starts 1 or 2 weeks before menstruation and peaks 1 or 2 days before menstruation. It ends with the menstruation. Abnormal bleeding is common. A physical exam reveals a nodule uterus and adnexal mass. We have here a clinical tip. Dysmenorrhea or dyspareunia are common for endometriosis. Diagnostic tests usually is made by direct visualization via laparoscopy. Direct visualization of the endometrial implant looks like rusty or dark brown lesions. On the ovary, like a cluster of lesions, is called chocolate cyst. The treatment is analgesia with NSAIDs. If there is a mouth symptoms, patient can be put on OCPs to interrupt the menstrual cycle and stop ovulation. Patients with moderate to severe symptoms should be placed on either danazol or Lepron. Both these drugs are used to decrease the FSH or LH. Danazol is a androgen derivate which is associated with acne, oil skin, and weight gain and hirsutism. Lupron is GnRH agonist, and when given continuously suppress estrogen. Also is associated with hot flashes and decreased bone density. Let's go to the next slide, slide number 24. We're almost finished. So be patient. On this figure 9.7, we have a microscopic sample for severe uterine abnormality which requires surgery, or chocolate cyst. Here, this slide says that surgical treatment is considered when the patient has severe symptoms or the patients are infertile. Surgery attempts to remove all the endometrial implants and adhesions and restore the pelvic anatomy. Patients who have complicated their childbearing may undergo total abdominal hysterectomy and bilateral salpingo-oophorectomy. Wow, terrible. Let's discuss here so-called endometrial hyperplasia or carcinoma and endometrial carcinoma. Endometrial hyperplasia and carcinoma, they usually coexist. Majority cases occur secondary to chronic exposure of the endometrium to unopposed estrogen. They present with abnormal uterine bleeding or postmenstrual bleeding. Let's go to slide 25. And risk factors for for that are obesity, or obese or postmenstrual woman, PCOS, tamoxifen therapy, early menarche, late menopause, Lynch syndrome. The diagnosis of endometrial hyperplasia is by endometrial biopsy. Treatment is with hysterectomy, and we need to know that premenstrual woman who wishes to preserve fertility needs to go to progestin therapy. Next is ovarian abnormality. Polycystic ovarian syndrome, the symptoms are usually occur in women in reproductive age. The symptoms are amenorrhea or irregular menses, hirsutism or obesity, acne, DM type 2 because of increased insulin resistance. The diagnostic test is pelvic ultrasound, which shows bilateral and large ovaries with multiple cysts, free testosterone, will elevate secondary to high androgen. High androgen level and obesity lead to increased estrogen formation outside of the ovary. This stimulates the LH and inhibits FSH, which lead to LH and FSH ratio more than 3:1. Wow. On this slide 26, we see polycystic ovary seen on sonogram. Treatment is weight loss. Patients which are obese should cancel for weight loss, which will decrease of insulin resistance. OCP control the amount of estrogen and progesterone which are in the body. Both controls the estrogen level and prevents the endometrial hyperplasia. And clomiphene or metformin should be used in a patient which wish to conceive. Next is ovarian cancer. Let's go to the last slide, 27. Ovarian cancer. Among gynecological cancer, ovarian cancer is one of the leading causes of death. Wow. Usually presents with acute or subacute. Acute presentations such as pleural effusions or bowel obstruction indicates late disease and poor prognosis. Subacute presentation is usually abdominal pain or adnexal mass, which occur either early or late in the disease. Symptoms include bloating, urinary urgency, urinary frequency, feeling full quickly, pelvic pain, and abdominal pain. Usually because of subacute presentation, there are many non-specific symptoms, and it's diagnosed late till late in the disease. Diagnosis is done by pelvic ultrasound or CT of the pelvis. No screening test for the general population, and family history or ovarian cancer are indication for so-called BRCA gene screening. And once again, thank you so much for your patience. This is again Professor Triple N, or Nick PA from Brooklyn, New York. If you have any questions or suggestions, please email me to my email, nickmd1@gmail.com. Thank you.